Hello, welcome to another installment of Pathology Scuba, where we dive into disease pathogenesis. I'm Pratima Singh, and today we're going to be talking about paraneoplastic syndromes. This is a big topic, so we're going to take the three most common paraneoplastic syndromes, and we're going to discuss how the pathogenesis of these syndromes is linked to how these disease processes manifest. Again, this material is for medical students learning about pathology. It would be hard to understand if you have no pre-existing biomedical information. And again, this is not covered to the extent that would benefit a practicing physician. So with that in mind, let's talk about what defines a paraneoplastic syndrome. If you have a tumor, such as lung cancer, that is growing, multiple complications can ensue. Some of these complications include things like airway obstruction, growth of the tumor into vascular walls causing rupture and subsequent hemorrhage, superior vena cava syndrome, where the SVC is compressed, compression of the spinal cord, Horner syndrome, where the sympathetic trunk becomes invaded and compressed by tumor. But none of these are paraneoplastic syndromes because these are all the result of mass effect of the tumor, either compressing or growing into structures. What a paraneoplastic syndrome is defined by is when either a tumor secretes a substance, such as parathyroid hormone-related protein, or ACTH, or when a tumor induces or evokes the elaboration of other factors like autoantibodies or cytokines. These define paraneoplastic syndromes. So why is it important to learn about paraneoplastic syndromes? Broadly, there's two reasons we need to care. First of all, in a patient with known cancer, we need to anticipate the potential complications of paraneoplastic syndromes associated with that tumor. Conversely, we might not know a patient has cancer, and the first indication that a patient has a malignancy may be their manifestation of a paraneoplastic syndrome. So using the latter example, where someone's going to present with symptoms and signs of a paraneoplastic syndrome, we're going to go through three case studies. We're going to talk about Mr. Peter Harp, Ms. Andrea Van Pelt, and Mr. Jack Thatcher. So the first case we'll talk about is going to be an example of humoral hypercalcemia of malignancy. And I'm giving away the final diagnosis because I want you to absorb all this information as we go through as being indicative of humoral hypercalcemia of malignancy. So Peter Harp presents. He's a 68-year-old man who has a 50-pack year smoking history. And the reason he's presenting to the emergency department is because he has mental status changes. On examination, Mr. Harp is definitely drowsy and confused. His calcium level is elevated at 14.8. His phosphorus is low at 1.7. Now, this should trigger the thought of parathyroid hormone because this would be classic for either primary or secondary hyperparathyroidism. But you check a PTH level and it's actually suppressed. It's low. The next question to ask is, what would cause a hypercalcemic hypophosphatemic state if it's not driven by PTH? So with Mr. Peter Harp, we decided to do another test. And the test we do is PTHRP, parathyroid hormone-related protein, sometimes called parathyroid hormone-related peptide. And sure enough, the PTHRP shows an elevation of 49. This is very suggestive of humoral hypercalcemia of malignancy. Hypercalcemia can result from malignancy through multiple pathways. Humoral hypercalcemia of malignancy is essentially when a secreted substance results in elevations of calcium. And you can see normal calcium homeostasis in the diagram here on the right. The most common cause of humoral hypercalcemia of malignancy is by far parathyroid hormone-related protein, which is associated with multiple tumors, including squamous carcinomas of any site, but lung in particular, cancers of the breast, gastrointestinal tract, and genitourinary tract. If you look at the diagram over on the right, you see where PTH, or normal parathyroid hormone, has a role. Well, parathyroid hormone-related protein will essentially do the same things that parathyroid hormone will do. So through increased calcium resorption from the bone, through elevations of calcium through renal-mediated retention, both of these mechanisms, similar to parathyroid hormone, result from elevations in parathyroid hormone-related protein. As a side note, another way that humoral hypercalcemia of malignancy may occur is associated with certain lymphomas that can secrete vitamin D. So, through normal mechanisms of vitamin D, elevations caused by lymphomas can also result in humoral hypercalcemia of malignancy. Another mechanism through which malignant tumors can cause hypercalcemia is local osteolytic hypercalcemia. And this is where a tumor is directly involving the bone, causing destruction and release of calcium. Breast carcinoma that's widely metastatic to bone can do this. Myeloma occurring within bones can do this as well. However, again, this is not a paraneoplastic syndrome. This is the direct effect of tumors destroying bone. So with Mr. Peter Harp, we know that he has elevations in PTHrP associated with hypercalcemia, so we are going to start investigating him for what malignant process he might have. This is a common issue when someone comes in with a paraneoplastic syndrome and no pre-existing diagnosis of carcinoma. So you have to figure out what kind of carcinoma he may have. And as I mentioned, PTHrP elevations may be seen in multiple different types of tumors: lung, breast, GI, GU tumors. So you have to go back and identify what he might be most likely to have. And this is true, again, of most paraneoplastic syndromes because there are very few paraneoplastic syndromes that are associated with just one type of tumor. So in this case of PTHrP, which of the following would be most likely for Mr. Peter Harp? Go back to his history, and you'll identify pretty readily that there is one factor in there that's going to make us look at one of those possibilities before others. With a smoking history, we're going to investigate the possibility of lung carcinoma being responsible for his hypercalcemia. And sure enough, we do a CT scan, and it does show a right hilar lung mass. And for those of you who remember what I said about lung cancer histology and where certain tumors arise, you might already be thinking about what this particular tumor that is encroaching on the bronchus itself might be. And indeed, the biopsy shows a histology of squamous carcinoma of the lung. This is a classic histology of squamous carcinoma of the lung with invasive squamous nests showing keratin associated with some of the tumor cells, that dark red appearance, and even some keratin pearl formation. So this is classic histology of squamous carcinoma. This is a case of Peter Harp, a gentleman who presented with hypercalcemia as a paraneoplastic syndrome, and it was caused by a squamous carcinoma of the lung elaborating parathyroid hormone-related protein. Now it's time to move along to case number 2. This is Miss Andrea Van Pelt, and she's going to have a paraneoplastic syndrome of inappropriate ADH secretion, or SIADH. Let's look at her case. She's a 52-year-old woman, and she has quite a heavy smoking history for her age. Now, she's seeing her primary care physician because she has increased lethargy and weakness. Examination shows that Ms. Van Pelt is indeed drowsy and irritable. She does have a normal blood pressure. She is euvolemic. Her plasma sodium is low. It's 118. Her serum osmolality is also low. Her urine osmolality is increased. So the question about her physiology then becomes, why is she inappropriately reclaiming free water? Why is she watering down her serum while her urine is so concentrated? That's inappropriate. Well, Ms. Van Pelt has SIADH, and it's mediated through arginine vasopressin, also known as antidiuretic hormone. So vasopressin and ADH, they are the same thing, and she's inappropriately elaborating that. So once again, we turn to her clinical history, and we note that she does indeed have a significant smoking history. We're going to look at the lungs. And unfortunately, her radiology does indeed show a lung mass. Now we can ascertain that it's likely that her lung mass is causing vasopressin secretion, which affects the kidneys to reclaim that free water and water down her serum, causing that symptomatic hyponatremia. Incidentally, the diagnosis of SIADH is quite complex and a little bit outside of the scope of this particular lecture. So a biopsy is taken, and this time it shows these cells that are molded up against each other, that have high nuclear to cytoplasmic ratios, have dispersed chromatin within their nuclei, and this is small cell neuroendocrine carcinoma. Small cell neuroendocrine carcinoma is associated with SIADH in up to 15% of cases. So this particular phenomenon is very important to be aware of. Again, we talk about why we need to know about paraneoplastic syndromes. Recall that one reason is that if you have a patient with a known diagnosis, you need to anticipate the potential manifestation of these paraneoplastic syndromes downstream. So if you had a patient who was diagnosed with small cell carcinoma of the lung, you might need to know that monitoring them for hyponatremia will be important as they may develop SIADH. Small cell neuroendocrine carcinoma is a very important tumor to be aware of, having a very high rate of not just endocrine but neurologic paraneoplastic syndromes that may occur in association with this particular tumor. There are other tumors that can produce SIADH. Apart from small cell carcinoma of the lung, you can have squamous carcinomas of the lung responsible as well. Gastrointestinal malignancies, genitourinary and ovarian carcinomas can do this, but this is Miss Andrea Van Pelt, and she has SIADH resulting from small cell neuroendocrine carcinoma of the lung. Now we will move along to case number 3. This patient's name is Jack Thatcher, and he's going to be an example of the third paraneoplastic syndrome we'll talk about, which is Cushing syndrome. Jack Thatcher is a 48-year-old man, and he presents with just new onset hypertension. He has this elevated blood pressure. Further evaluation shows other abnormalities. His potassium is low. He's had some weight loss, 8 pounds over 2 months. He has muscle weakness, and you actually notice that he seems to have some muscle wasting. So what test should we perform next? Keep in mind he's got hypertension, hypokalemia, muscle wasting, and weakness. So one of the things we would like to check is his morning serum cortisol, which is elevated. And an ACTH level also shows elevation. So this is diagnostic of hypercortisolism caused by ACTH secretion. This is a form of Cushing syndrome. Mr. Jack Thatcher has paraneoplastic Cushing syndrome mediated by ACTH, adrenocorticotropic hormone. So let's back up and talk about various causes of hypercortisolism. In the classic Cushing disease, hypercortisolism is caused by a pituitary adenoma secreting ACTH. In adrenal disease, you can get hypercortisolism by the adrenal gland inappropriately secreting excess levels of cortisol. And then there's ectopic ACTH secretion, where an outside source is responsible for secreting ACTH, stimulating cortisol production by the adrenals. And when you have ectopic ACTH secretion, you are typically talking about a paraneoplastic syndrome. So Cushing syndrome, caused by various types of cancers, as listed below. When we think about Cushing syndrome, we think about certain signs of Cushing syndrome. These can include centripetal obesity. This can also include the development of moon phases. These are pictures of the same woman taken at 1-year intervals as moon phases really develops in her Cushing syndrome. Other classic signs include these violaceous abdominal stria, thinning of the skin, and vellus hirsutism. Our patient, Mr. Jack Thatcher, does not have those signs, although you could argue about the hirsutism, but he does not have centripetal obesity. He does not have abdominal stria. He does not have moon phases. So why is that? The classic signs of Cushing syndrome, when caused by a pituitary adenoma secreting ACTH or hyperadrenalism, include those classic signs. Mr. Jack Thatcher has an ectopic paraneoplastic source of ACTH, and his signs will be different. They will include hypertension, hypocalcemia, metabolic alkalosis, and muscle wasting. So let's explore that. What's important to understand is that paraneoplastic Cushing syndrome will result in different signs. The reason why this is because this phenomenon will be more rapid in onset. So the chronic nature of classic Cushing syndromes, whether they're pituitary or adrenal mediated, will not have time to really develop. Also, the classic obesity that occurs in association with Cushing syndrome would not be present in paraneoplastic Cushing syndrome because the primary cancer is going to cause typical cancer cachexia, wasting. So that will dominate the patient's signs. Another unique feature of paraneoplastic Cushing syndrome is the result of the test called high-dose dexamethasone suppression testing. Essentially, when you are looking at an ACTH elevation and you're trying to figure out where it's coming from, you can give high-dose dexamethasone. If you have a pituitary adenoma that is responsible for secreting ACTH, if you give a high dose of dexamethasone, a pituitary adenoma typically will suppress ACTH production. Conversely, if you have a lung tumor, for example, that is secreting ACTH, even if you give a high dose of dexamethasone, this lung tumor will not suppress ACTH. It will continue to secrete ACTH. So this is another unique feature. Another issue with paraneoplastic Cushing syndrome is that by the time it comes to light, these tumors tend to show advanced spread. These tumors tend to be very aggressive. So once you have identified it, it's often hard to treat because of the spread of that particular malignancy. One thing that was not mentioned, Jack Thatcher has a significant smoking history. So sure enough, radiography shows that Mr. Jack Thatcher has a lung tumor, and biopsy shows small cell neuroendocrine carcinoma, the same tumor that Miss Andrea Van Pelt has. However, in Mr. Jack Thatcher's case, his small cell neuroendocrine carcinoma of the lung is secreting ACTH, so it is responsible for hypercortisolism because of ACTH secretion. This is paraneoplastic Cushing syndrome. So why did I use small cell neuroendocrine carcinoma again for our third patient? Well, Mr. Jack Thatcher's small cell neuroendocrine carcinoma is important to take note of because Cushing syndrome is actually the second most common paraneoplastic syndrome in small cell neuroendocrine carcinoma, occurring in up to 5% of cases. This might make you ask, could you actually have small cell neuroendocrine carcinoma and have both ACTH production and SIADH? And the answer is yes, you can. So remember, again, small cell neuroendocrine carcinoma can cause multitudes of endocrine and neurologic paraneoplastic syndromes. There are other tumors that are associated with ectopic ACTH secretion, like other tumors of the lung, bronchial carcinoid tumors, pancreatic islet tumors, medullary thyroid carcinomas, pheochromocytomas. However, this gentleman here is our patient, Mr. Jack Thatcher, and he has ACTH secretion causing Cushing syndrome because he has a small cell neuroendocrine carcinoma of the lung. So in summary, we've covered the case of Mr. Peter Harp, a gentleman who had squamous carcinoma of the lung causing PTHRP-mediated hypercalcemia of malignancy. We discussed Miss Andrea Van Pelt, who had a small cell neuroendocrine carcinoma of the lung, which was secreting vasopressin and causing SIADH, or syndrome of inappropriate ADH secretion. And then finally, we had Mr. Jack Thatcher, who similarly had a small cell neuroendocrine carcinoma of the lung secreting ACTH, giving him unique manifestations of paraneoplastic Cushing syndrome. Thank you for watching this installment of Pathology Scuba. If you haven't subscribed already, you may want to do so if you want to see more pathology randomness. Share these videos with other students if you think it would help them, and please send me any comments or ideas or questions to my Gmail account. I've been Pratima Singh. Thank you for watching.